The patient is a 21-year-old medical student who has spent 2 years in a state of treatment-refractory anxiety. His current management involves a dense polypharmacy regimen, the SSRI sertraline, the tricyclic antidepressant imipramine, the beta blocker propranolol, and 2 long-acting benzodiazepines, clonazepam and diazepam. On paper, his physiological markers appear optimal: a resting heart rate of 67 beats per minute, blood pressure at 113/76, and an oxygen saturation of 100%. These figures fall within normative ranges. This stability is a product of chemical tethering. Propranolol, a beta-adrenergic antagonist, binds to the cardiac receptors to physically prevent the heart rate from rising. It effectively mutes the somatic expressions of the fight-or-flight response. Because the peripheral physiological release is blocked, the cognitive experience of anxiety remains compressed within the cortical and limbic structures, with no physical outlet. This persistent state indicates that specific pharmacological crosstalk and metabolic gaps are likely preventing the nervous system from initiating its own neuroplastic recovery. To find the source of the treatment failure, we must look at the hepatic metabolic level, specifically the cytochrome P450-2D6 enzyme, or CYP2D6. Sertraline acts as a potent competitive inhibitor. Occupying receptor sites on the CYP2D6 protein prevents the liver from processing other substances. Imipramine and propranolol require this exact enzyme for clearance. With the pathway blocked, these drugs cannot be broken down. This leads to an exponential increase in the plasma area under the curve for both medications, resulting in high, potentially toxic serum concentrations. This hepatic bottleneck forces a pharmacodynamic collision within the cardiac conduction system. First, the accelerant vector. Elevated imipramolol blocks the vagus nerve's parasympathetic influence, triggering tachycardia and delaying repolarization. Simultaneously, toxic propranolol provides the suppressant vector. It blocks sympathetic beta-1 tone, forcing the heart to slow down and depressing contraction strength. The heart is receiving intense competing instructions to both accelerate and decelerate. This creates an unstable electrophysiological environment, increasing the risk of arrhythmias and sudden orthostatic collapse. The pharmacological regimen is actively working against itself, creating a silent hemodynamic crisis in place of psychological relief. The issues extend to the patient's use of 2 long-acting benzodiazepines, clonazepam and diazepam. Both medications are positive allosteric modulators that target the exact same interface on the GABA-A receptor. Because they share a molecular mechanism, they provide no additional therapeutic benefit when used together. To compensate for this constant central nervous system depression, the brain must restore a level of excitability to maintain homeostasis. Through clathrin-mediated endocytosis, the neuron physically internalizes its own GABA-A receptors, removing them from the synaptic cleft. This downregulation makes the brain's natural GABA signaling ineffective. The patient becomes entirely dependent on the external drugs to maintain a baseline level of calm. For the brain to overcome anxiety, it must engage in fear extinction learning. This requires the prefrontal cortex to establish new synaptic connections with the amygdala, a process that depends on high-frequency neuronal firing. By design, benzodiazepines suppress the neuronal firing required for this rewiring to occur. By chemically silencing these cells, the dual benzodiazepine regimen actively prevents the brain from structurally adapting its way out of the fear response. We also have to consider why the sertraline is failing to elevate the patient's mood at a foundational level. The patient consumes a daily diet of processed carbohydrates containing high sodium levels and synthetic preservatives like BHA and BHT. These preservatives degrade the intestinal epithelial tight junctions. This allows lipopolysaccharides, bacterial endotoxins, to move from the gut directly into the systemic circulation. This endotoxemia triggers a release of pro-inflammatory cytokines, which is reflected in the patient's elevated hsCRP and IgE biomarkers. This systemic inflammation results in the upregulation of the indoleamine 2,3-dioxygenase, or IDO, enzyme within the central nervous system. Normally, the brain converts tryptophan into serotonin. However, upregulated IDO hijacks tryptophan, shunting it down an alternate pathway. This creates 2 problems. It starves the brain of serotonin precursors and produces quinolinic acid, persistently overstimulating NMDA receptors. This lack of neurotransmitter production is further worsened by a severe vitamin D deficiency, which measured at just 6.64 nanograms per milliliter. Vitamin D functions as a neuroactive serosteroid hormone, serving as a direct signal for genetic transcription in the brain. Its active form, calcitriol, is a requirement for the expression of the enzymes that synthesize both serotonin and dopamine. Without these genetic signals and metabolic precursors, the brain cannot manufacture the neurotransmitters that sertraline is designed to manage. We can now map these molecular failures onto the physical architecture of the brain. Under chronic excitotoxicity and without proper inhibition, the basolateral amygdala undergoes dendritic hypertrophy. It physically expands, becoming a hypersensitized threat center. Simultaneously, the ventromedial prefrontal cortex, the center for logical control, experiences dendritic atrophy. It loses its structural connectivity to the amygdala. The hippocampus also loses physical volume, which destroys the brain's ability to differentiate between safe environments and genuine threats. In this state, the patient cannot think his way out of anxiety because the logical centers of the brain have lost their physical wiring to the emotional fear center. Recovery requires a physician-led rationalization of the drug regimen to resolve the enzyme inhibition and therapeutic duplication. A structured taper of the benzodiazepines is necessary to allow the GABA receptors to safely return to the cell surface. Replenishing vitamin D levels is essential to restart the genetic production of neurotransmitters. Removing processed dietary inputs can help heal the gut-brain axis and stop the diversion of tryptophan away from the serotonin pathway. Only once the biological environment is stabilized can behavioral changes stimulate the neuroplasticity required for a permanent shift in the brain's fear response. Pharmacology alone cannot cure a refractory disorder. It is the optimization of the biological substrate that allows the brain to finally rewire itself.